Colonic pseudo-obstruction. It is defined as an acute pseudo-obstruction and dilatation of the colon in the absence of any mechanical obstruction. Usually seen in people over 60 years of age, and there is a male predilection. Clinical features resemble those of mechanical obstruction. Pathogenesis of colonic dilatation without obstruction has led to a variety of terms for the disease, including pseudoobstruction, Ogilvies syndrome, false colonic obstruction, pseudomegacolon, adult megacolon, adynamic ileus, functional obstruction, and idiopathic large bowel obstruction. Despite the absence of an obstructing lesion, particularly acute colonic distension can be rapidly progressive and lead to necrosis and perforation of the large bowel. Especially if dilatation is severe, bowel necrosis and perforation, which in turn can go on to become generalized peritonitis. Incorrect diagnosis of mechanical obstruction can lead to unnecessary surgery. Pseudoobstruction of the colon is often mistaken both clinically and radiologically for other abnormal conditions. Differential diagnosis: adynamic ileus or paralytic ileus, mechanical large bowel obstruction, toxic megacolon, ischemic colitis, sigmoid volvulus and caecal volvulus. Pathology: colonic pseudo-obstruction is related to decreased parasympathetic activity. Risk factors include trauma, burns, recent surgery, medications, respiratory failure, electrolyte disturbances, diabetes mellitus, uremia, neurological disease. Postpartum, plain radiograph. Findings can be identical to a mechanical large bowel obstruction. Fluoroscopy. A single contrast water-soluble enema demonstrates the absence of any mechanical obstruction. CT. The hallmark of colonic pseudo-obstruction is the presence of dilatation of the large bowel without evidence of an abrupt transition point or mechanically obstructing lesion. Decompression is usually undertaken if the colon caliber is more than 9–12 cm.